everyone. So welcome. I'd like to say welcome in Lille, France, but in fact it's in a different place for everyone. So you're still very welcome to attend this conference on intracranial atherosclerosis with WSO, and we'll have exciting talks. I'm just waiting for everybody to find a seat. Usually we say, there's room at the front row, please come. So I suppose we will start now. So today we'll talk about intracranial atherosclerosis, and we've got 3 speakers who will give 3 talks of 10 minutes, and then we will have the questions, and I'm happy to co-chair this meeting with Dr. Nils Henninger from the University of Massachusetts in the US. So you will put your questions on the Q&A box, and we'll deal with them at the end of the free talk. So now we will welcome Dr. Gutierrez, who is an assistant professor in Columbia University, New York, and the floor is yours.
Thank you very much. Good morning or good afternoon, everyone, depending on where you are. Good morning, New York. I will share with you my slides in a second. I think you should be able to see them now. And so I'm going to talk to you today about the epidemiology, the diagnosis, and outcomes of a stroke in the setting of intracranial atherosclerosis. My disclosures are related to NIH funding. I have no other commercial interest. And so regarding the prevalence of stenosis, we have to put attention to where the samples come from and what the details are in terms of workup. But in general, hospital-based samples demonstrate that the prevalence of intracranial atherosclerosis-related stroke is higher in samples from Asia and or in ethnic minorities in the Western world, especially in the US, where we tend to report the prevalence or incidence by ethnicity. It's important to emphasize, again, the hospital-based, because if you think about this is people that come to the hospital that we doctors see and treat for stroke. But what's happening out there, what's happening in the general population, we don't have a lot of as many data as we have from hospital-based samples, but we do have some. So in the United States, there's 2 studies, to my knowledge, that have a true population measurement of the burden of atherosclerosis. And one is ERIC, that includes 4 cities across the United States. It's mostly African-American and non-Hispanic whites. In about 1,900 people, they have done MRAs. These individuals are not from a hospital. They live on their houses and they get recruited to the study via random methods. So it's closer to a true mean of the population. In this sample, the prevalence of any stenosis, okay, not the typical more than 50% stenosis or more than 70% stenosis we see in the hospital, but any stenosis is 34%. So very important number. 1/3 of the population has something in terms of luminal stenosis. In the Northern Manhattan study here in New York, we have, it's a multi-ethnic cohort included by non-Hispanic white, non-Hispanic blacks, and Hispanics, and the prevalence of any intracranial stenosis is 40%. And if we define it as stenosis more than 50%, which perhaps clinicians will be more familiar with, the prevalence is 8%. So still 8% of the general population have intracranial stenosis, and that's a pretty important number. And across the world, I know of another study in Singapore called the EPIDEMIOLOGY, and which also reflects selected individuals, 1/3 of them of Chinese background, the other 1/3 Indian background, and the other one Malay. And in this sample, stenosis more than 50% was 8%, similar to what NOMAS found in Northern Manhattan. So very interesting that across countries in unselected populations, the prevalence of high degree stenosis is similar. And in terms of risk factors for intracranial atherosclerosis, well, there's consistent across the board in its aging. That's pretty universal. Higher systolic blood pressure, that's how this study looked into it, but you can use also surrogate of hypertension. Dyslipidemia, specifically high cholesterol, high LDL, diabetes, and decreased physical activity. I guess there's no surprise in this. And so in terms of diagnosis, the gold standard to diagnose atherosclerosis is pathology. And that's because the word itself derives from the word atheroma or athera from ancient Greek that means gruel-like. And for those who are not used to this, well, this is gruel. You may like it or not, but this is how it looks like. And so this is what athero should like. So you have to show me the gruel to tell me this is athero, okay? In pathological studies that you read in places that they do autopsies, I can bet you that most of the diagnosis of athero in pathology is done this way. So people look at macroscopic specimens and they see these whitish spots and they call that athero. But I urge caution about that approach because not all that shows white on the surface actually has gruel when you cut through. And you can see this case of an individual who had a fusiform dilatation who eventually ruptured and died, and we were able to obtain his vessels. And you can see that right here, I'm cutting through the whitish spot and there is no gruel. I just show you what the gruel looks like in pathology. And if we looked at a cross-section of this specimen, you see no gruel. It's just a degenerated wall. And similarly, all the vessels on this individual have no evidence of cholesterol deposition. So if a pathologist tells you that there is athero because they looked at the circle of Willis, do not settle by that. Ask them to cut it through and show you the gruel in a histopathological section. Now, atheromas are foci of inflammation. You can see here the CD68 surrounding that stands for macrophages surrounding the necrotic core. This inflammation can actually occur in specimens with substenotic plaque burden. And you can see here that, again, the macrophages are near the surface of the intima thickening. There's extensive tissue remodeling as expressed by metalloproteinases. And it is conceivable that at one point this luminal erosion could potentially expose thrombogenic material to the lumen, therefore causing thrombosis. And this inflammation can also cause plaque rupture. And I show you here an example of one. You can clearly see the gruel again right here. And you can see how in one of the shoulders of the fibrous scab that is very thin, there's a rupture. And this rupture eventually leads to thrombosis. You can see the beginning of a clot, and I shave off the blood here inside the vessel, but you can see how this happens. This is what people call a plaque rupture, which then triggers thrombosis. And Dr. Yaghi will tell you later about this mechanism, but I just wanted you to see it with your eyes. However, pathology is not very practical. We all know that. And so in clinical matters, we use lumen as a surrogate of stenosis, but just a note of caution, again, not all luminal stenosis are atherosclerosis. And here, there's a list of differentials that can give you stenosis. And without the context, we don't really know. And I'm just going to show you examples again from the brain arterial arterial remodeling study, the bars here at Columbia. And you can have here a heel dissection that impinges into the lumen. You can have a partially recanalized clot here that gets into the wall, gets attached to the wall, reduces the lumen, and has no gruel. This is just a clot. There's another phenotype that perhaps is less common to the attendees that relate to non-atherosclerotic brain arterial aging that has to do with just the flow. Decades of blood flow through the lumen cause intima thickening that is concentric, and you can clearly see here that internal to the elastic lamina, there's quite a bit of intima thickening and the lumen seems narrower. So if you remove this area of intima thickening, you can see that the lumen was at least 50% larger. And here I put numbers to what I said. In thousands of vessels that we measure in the brain artery remodeling study, you can see that in the specimens or the pathological diagnosis that includes cholesterol, which is again the core diagnosis of athero, there is stenosis, no question about it. But in the other phenotype in which the vessel is degenerated, but there's no cholesterol, there's no gruel, there's no atheroma, there's also stenosis. So just a note of caution when you see stenosis. We do and can assume sometimes that it's atherosclerotic, but you have to be careful. It's better to actually say stenosis as opposed to atherosclerosis. And across the older groups, so 60 or 80 or 80 or older, you can see that there's going to be people that are going to have a predominant atherosclerotic phenotype, but others will have no cholesterol in the brain vessels and may also have a stenosis, just FYI. Now, how do we measure the stenosis? How do we measure the lumen? So currently the gold standard is catheter angiography or DSA, or call it however you want to. But this study is invasive, is expensive, and is not practical to most stroke patients. So alternatives to diagnose luminal stenosis in the brain includes brain MRA, which can be time of flight, which does not require contrast, or a contrasted study. We can use a CTA or we can use transcranial Doppler. So how do they compare? So comparing MRA with 1.5 time of flight to DSA, we see that the sensitivity is more than 90%, same for specificity. And as we all know, there's a possibility that MRA will overread the stenosis. So you got to be careful with MRA without contrast. If the stenosis is going to determine a given intervention, it may be better to assess the exact degree of stenosis with other methods. How does TCD compare against angiogram? It depends on what cutoff we use. So you can see the mean flow velocities on the NCA. If we use a low threshold of more than 80, you are very sensitive. You would pick up any stenosis, but you lose specificity, and the positive predictive value is only 84%. If you keep increasing the threshold, the mean flow volume, velocity, sorry, to 120, then you gain in specificity, but then you lose sensitivity. And it's also operator dependent, so it depends on how good your technician is and how systematic they are in carrying out the measurements. How does CTA compare with the angiogram? Again, it depends on the degree of stenosis. The greater the stenosis, the better the CT is against DSA. Now, this is from late 1990s, but newer scanners are probably even better than these numbers because they have thinner cuts and they do some different rendering of the images. But even then, 20 years ago, it was already pretty comparable or good against DSA. So in summary, most people would use CTA, MRA to look at a stenosis. I guess in Europe, TCD is more commonly used than here in the States, but they all methods are comparable to DSA in terms of sensitivity and specificity. And because at this point, we don't really need to precisely measure the stenosis, then there's no point at really doing an angiogram, except again, if you were to measure for stenting, for example. And so how do we measure stenosis? So there's two methods, the WASIT method and the NASIT method. So WASIT basically measures the area of the narrowest lumen here and compares it, what proportion this is from the proximal non-affected segment. And NASIT is the opposite. They take the distal segment. So what both methods do not take into account is that from the beginning of this an MCA, from the beginning of the MCA to the end of it, there's going to be a tapering because all these lenticular striates will give a flow, so the diameter is going to drop. And if you use the distal segment, as in the Nassett method, the consequence of that could be that if you don't take that into account, it's going to be smaller than it should be, and therefore underread the stenosis, which is actually shown here. So if you use the Nassett method, then you have a median stenosis of 48%. If you use it WASD, it's 55%. So there's about a minus 8% difference in general, but it range could be up to 50%. And again, it is because the distal segment is more variable than the proximal one. And there's another phenomena that may occur, and is the post-stenotic dilatation. So if an individual has very large post-stenotic vessels, then that would overread stenosis. And you can see the range here. It can go from minus 50% to 9% stenosis difference between the methods. So in general, and for the trials that we often quote in intracranial stenosis, we use the WASD method. Therefore, related to specifically WASD trial. So the latest wave of technology regarding diagnosis is high resolution intracranial wall imaging. And this aims to complement the MRA and sometimes replacing it by looking at the actual wall. And you can see phenotypes such as a possible culprit plaque because there's contrast enhancement. You can see here in this A2 segment corresponds to this flow gap in the MRA. And you can see clearly the wall enhancing in that A1 segment. Now, the advantages is that this is a more comprehensive evaluation of the atherosclerotic process than lumen-based studies, and I just show you why with pathology. Another advantage is that it's able to inform about possible differentials, and you can evaluate culprit plaques. The disadvantages is that it's not readily available outside academic centers. You require at least a 3T magnet to get a good signal to noise ratio. The resolution still is 0.5 millimeters per voxel in the best case, which is greater than the median size of an arterial vessel that is 2 to 3 millimeters. So there's some work to do here. And also, this technology has now been validated to select individuals for specific interventions. So the take-home message is that intracranial atherosclerosis is one of the most important causes of a stroke in the world, that intracranial atherosclerosis and related stroke is more prevalent in hospital-based samples from Asian countries and ethnic minorities in the United States. Ethnic disparities are partially explained by higher prevalence of risk factors in these groups. Conventional and non-invasive methods to measure the degree of intracranial stenosis have overall good performance and can be used. We can use lumen-based stenosis as a surrogate of atherosclerosis, but we have to be careful with the context, the clinical context, and be mindful of differentials. Asymptomatic intracranial athero is a risk factor for vascular events, as I just showed you in the Northern Manhattan study. And intracranial stenosis-related stroke have poor functional outcomes. I skipped that for the sake of time. Where I think we should go, 3 directions. 1, we should start thinking about primary prevention to prevent 3 out of 4 strokes, as opposed to just secondary stroke prevention that prevents 1 of 4. We should investigate whether novel, either genetic, inflammatory, or infectious markers could help us increase the specificity of stenosis towards athero. And we should think of trials that use high resolution wall imaging, which is the new technology in the field, and see whether that adds on something to actual just the lumen. And thank you all for your attention. I'll be available later for questions.
Thank you very much for your talk, Jose. So now we will move to the second talk about mechanism recurrence prevention with Dr. Shadhi Yaghi for across town, I just learned, in New York University, where he's an assistant professor of neurology.
Good morning from New York. I hope everyone is doing well amidst the devastating COVID pandemic. I'd like to thank the World Stroke Organization for arranging this webinar and for having me among the panelists. I'm going to be talking about intracranial atherosclerosis, mechanisms, secondary prevention, and recurrence risk. Here are my disclosures. So a little bit of background about intracranial atherosclerosis. It accounts for nearly 10% of ischemic strokes in the United States and up to 50% of strokes in China. Symptomatic large vessel atherosclerosis is an important predictor of early recurrence that has been shown in several studies. And the SAMMPRIS study that looked at intracranial atherosclerosis showed that the risk of recurrent events in patients on medical treatment is nearly 12% at 1 year and 20% at 2 years from the initial event, which is a relatively high risk of recurrent stroke. So what are the medical treatment options? There are several studies investigating medical treatment. One of the earliest studies is the WSO study that compared warfarin to aspirin in patients with symptomatic intracranial stenosis. This study showed no benefit of warfarin over aspirin in these patients. There are several recent trials, not necessarily limited to intracranial atherosclerosis, but did include patients with this disease. And these 3 randomized control trials showed that a short duration, 21 to 90 days of dual antiplatelet therapy is associated with a reduced risk of recurrence. High intensity statin also is a very important treatment strategy that has also been shown to be very effective in the SPARKLE randomized control trial. Insulin sensitizers were studied in the IRIS trial, and also these have been shown to reduce the risk of recurrent stroke in patients who have insulin resistance. This was not limited to intracranial atherosclerosis, but it did include patients with intracranial atherosclerosis, and subgroup analyses show the benefit in this patient population. Diabetes control is also an important strategy in reducing the risk of stroke in these patients. There are some studies that should suggest that in patients with flow-limiting stenosis, perhaps early permissive hypertension is associated with a reduced risk of recurrence. But we know that long-term blood pressure control is very important, and this has been shown in a post-hoc analysis of the SAMMPRIS trial. And definitely lifestyle modifications, they're extremely important in reducing the risk. Diet, exercise. Exercise actually in the SAMMPRIS study has been shown to be one of the most important strategies in reducing the risk of recurrent stroke in patients with intracranial atherosclerosis. So all these treatment strategies are extremely important in reducing the risk, and they are very effective in this patient population. But the question that comes is, does medical treatment work for everyone? And this is a nice KM graph comparing SAMMPRIS to WSO, and this is the SAMMPRIS medical arm, and this is the WSO trial patient cohort. And you can see between WSO and SAMMPRIS, we've done a really good job in reducing the risk of recurrence in patients with intracranial atherosclerosis treated medically. So medical treatment has significantly improved over the past decade or so. However, even if you look at the SAMMPRIS KM graph, you can see that the risk even in SAMMPRIS, as I mentioned earlier, is not low. It's about 12% at 1 year and about 24% or 20% at 2 years. So this risk remains high. And in real world studies, and even in patients treated using the SAMMPRIS protocol, the risk is even higher. It's up to 20 to 25% at 90 days in symptomatic intracranial atherosclerosis patients. So there's still a lot of work to be done in reducing the risk of recurrence in these patients. So why do patients fail medical treatment? Obviously, inadequate medical treatment, poor risk factor control, unhealthy lifestyle, physical inactivity. All these are factors that contribute to the recurrence risk in this patient population. But another important factor that I'm gonna, argue in the next few slides that is also an important factor to consider is that the treatment that we're providing does not target the underlying mechanism of recurrence. So what are the mechanisms of stroke in patients with intracranial atherosclerosis? These are important mechanisms. Artery-to-artery embolism, as Dr. Gutierrez said, mentioned in his talk, there's this unstable plaque that ruptures and then small pieces break off and travel downstream, and these can lead to stroke that's related to artery-to-artery embolism. The plaque can occlude the lumen of those or extend into the perforators, especially in the middle cerebral artery and the basilar artery, for instance, and cause a perforator infarct. Another mechanism is the plaque can cause severe narrowing of the lumen, and it can limit distal blood flow and cause impaired distal perfusion that may lead to infarct related to perfusion failure. So I'm gonna provide with two examples, one of each case, one of each mechanism. So this is a 75-year-old woman with a history of hypertension, admitted with mild dysarthria. On exam, she had very mild dysarthria and a right facial droop, and she had a CT and a CT angio. And on the CT angio, you can see she had severe middle cerebral artery stenosis on the left. She was treated with dual antiplatelets, high intensity statin, and she underwent perfusion imaging, and this was her perfusion. So she had a significant 61 ml volume of Tmax more than 6, and she had a very small infarct. And the standard of care for these patients is medical treatment. She was treated with medical treatment. We watched her in the hospital for a few days. She continued to do well, and she was discharged home. And unfortunately, she comes back with right hemiparesis and aphasia. And now a repeat MRI still shows some perfusion deficit, but as you can see, the infarct has extended. So she was treated with intravenous phenylephrine and transitioned to oral midodrine and Florinef to improve her distal flow. Her exam stabilized, and on 90-day follow-up, she had right-sided weakness and vascular cognitive impairment, and her modified Rankin scale was 4. Another case, 65-year-old with history of hypertension, hyperlipidemia, and a history of a left medullary pyramidal infarct related to vertebral artery athero, admitted for transient dizziness. On exam, he had his mild chronic right hemiparesis, and this was his imaging. He has severe atherosclerosis in both vertebral artery, the left and the right, more severe on the left, and he had a small punctate cerebellar infarct. At the time, he was switched from aspirin to Plavix and was continued on high-intensity statin therapy. 7 days later, he comes back with transient dizziness, and he underwent an MRI that showed a small occipital infarct as well as a small cerebellar infarct. He had some additional testing, and he had vessel wall imaging. Also, Dr. Gutierrez talked a little bit about it. So as you can see, there's enhancement of the atherosclerotic plaque in the left vertebral artery. We did transcranial Doppler with HITS monitoring to see if there's any microemboli, and we found active embolization in the basilar artery. You can see this is a high-intensity transient signal on transcranial Doppler, suggesting that there's active embolization. He had a perfusion study that showed mild Tmax delay in the posterior circulation. He was treated with dual antiplatelet therapy, high-intensity statin. The dual antiplatelet therapy was for 90 days, followed by a single agent, and his risk factors were controlled, encouraged a healthy lifestyle, and he was followed for up to 2 years, and he was event-free. So the hypothesis is that in patients with intracranial atherosclerosis and impaired distal perfusion, it's unlikely that medical treatment alone will acutely improve distal perfusion and prevent neurological deterioration, this subgroup of patients may benefit from reperfusion. So has perfusion been studied in patients with atherosclerotic disease? We did the pilot study a few years ago. We looked at 62 patients with large vessel disease, extracranial carotid occlusion, or ICAD, who underwent MR perfusion with rapid. We defined impaired perfusion as Tmax more than 6 mismatch volume of 15 ml or more, and the outcome was recurrent cerebrovascular events within 90 days. And this shows the KM curve. So 14 patients had unfavorable perfusion. They had a mismatch. 48 had favorable perfusion. And you can see the curve split in the first few days. And there's a significantly higher risk of recurrent stroke in patients with unfavorable perfusion. And I can tell you most of these patients were treated with maximal medical treatment, dual antiplatelets, and high intensity statin and risk factor modification. Looking at patients with intracranial atherosclerosis specifically, we looked at 26 patients with proximal anterior circulation intracranial athero and who underwent perfusion. Again, we looked at different thresholds of Tmax delay versus 90-day recurrence, and we found that there was higher risk of recurrence regardless of the delay, but the cutoff of more than 6 seconds seemed to perform the best. This study obviously is a very small study. The confidence intervals are wide, and it's a single center retrospective. These are all major limitations, and thus this needs to be validated. Another study looking at a different patient cohort also showed the exact same findings. Patients who had a mismatch shown in this red curve had a significantly higher risk of stroke compared to those who did not have a mismatch. Looking at the SAMMPRIS data, there were two post-hoc analyses of SAMMPRIS. One that was presented at the International Stroke Conference in 2016 showed that there's an association between Tmax delay on perfusion imaging and recurrent ischemic stroke at 90 days within the territory. Another interesting analysis looked at infarct pattern and showed that patients who have anterior circulation border zone infarcts have a higher risk of recurrence. And in fact, there were 55 patients treated with stenting across these patients who had anterior circulation border zone infarcts. 55 were treated with stenting and 53 with medical treatment. And you can see there were fewer events in the stenting treated patients, but obviously the sample size is small, and this is underpowered to detect a significant difference between the two groups. Also, infarct pattern was looked at in another single center study. 212 patients with symptomatic intracranial athero border zone infarcts were present in about 25% of patients, and the recurrence risk in the territory was 24%. And in adjusted analyses, the presence of a border zone infarct was independently associated with recurrent stroke. So another way to look at distal flow indirectly is looking at the collaterals. The collateral circulation, it's a compensatory mechanism for blood flow impairment across a stenosis. A really nice post-hoc analysis of WSO showed that in patients who have poor or no collaterals, the risk of recurrent stroke was significantly higher than those who had good collateral flow. Interestingly, that all these markers of impaired flow correlate with each other. So we did a study that showed that there's a strong correlation between infarct pattern and perfusion and impaired distal perfusion. This is an example in our publication last year. So this is, for instance, a patient with a border zone infarct, and you can see they had a large area of mismatch or perfusion delay. This is a patient with a core infarct who had no perfusion delay. This is a patient with a perforator infarct who had minimal perfusion delay. And this is a patient with a cortical border zone infarct who had some perfusion and delay as well.
Can you go to your conclusion now?
Yes, okay. As a take-home message, medical treatment has improved in reducing stroke recurrence in patients with intracranial atherosclerosis. Some patients, however, are at risk of recurrence despite optimal medical treatment. Targeting the underlying mechanism is important. So in patients with artery-to-artery embolism, optimal medical treatment is an important strategy. Similarly, in patients with perforator disease, whereas in patients with impaired perfusion, optimal medical treatment remains important, but we need clinical trials to study further treatment strategies to improve distal blood flow. Future directions, studies are needed to test strategies that would further optimize medical treatment, such as PCSK9 inhibitors and anti-inflammatory medications such as colchicine and other drugs to optimize, as well as optimizing antithrombotic regimens. Studies are needed to better define impaired blood flow and perfusion in patients with intracranial atherosclerosis and select them for studies investigating reperfusion strategies. I'd like to thank you for your attention, and we'll be taking questions at the end.
Thank you, Dr. Shadhi. So, Dr. Yaghi, sorry.
Yes.
So now we go from New York to Switzerland, to Bern, where Dr. David Seiffge, who is an assistant professor, will talk about the endovascular treatment of those patients. We very often need to be a lot around the cases to be able to decide. So please help us.
Yeah, thank you, Charlotte, for your introduction. Do you see my slides?
Yes.
Wonderful. So thank you very much for this kind introduction. And I have no disclosures, and I will try to stick in time that we can have some questions. I can skip this slide, as you already know that intracranial atherosclerosis is relevant also for European populations, not only for Asians. So this is very hot new data from this year from the UK. You have heard about the SAMMPRIS trial, which actually is the landmark trial in the setting of stenting of intracranial atherosclerosis. Just to remind you, this was a randomized phase 3 trial, which included patients with a recent ischemic stroke or TIA, attributable to a intracranial stenosis of 70 to 99%. And patients were randomized to receive either stenting with the wingspan stent and aggressive medical therapy, or aggressive medical therapy alone, which was defined as aspirin 325 milligrams per day and clopidogrel 75 milligrams per day for 90 days, followed by monotherapy. But they also received statin therapy, blood pressure-lowering drugs, and so on. So they were well treated. Sample size was calculated for 451 patients. Primary endpoint was any stroke or death within 30 days. And then after 30 days, stroke in the territory of the qualifying artery. And the trial actually was stopped prematurely due to a high rate of any stroke and death in the stenting group. And this is what you can see in the slide. So you see there is a very high early increase in outcome events in the stenting group. And then both curves are more or less in parallel. There seems to be no much different, but as to the very early increase in events, there was a statistically significant harm from stenting in these patients. So these results have been discussed a lot in the past, and one of the major points was that actually aggressive medical therapy was much more effective than we thought. So the primary endpoint occurred much less often in the medical care group than expected from prior data, but there were also some challenges around stenting. Actually, periprocedural risk was high. One aspect was probably that this was a self-expanding stent that requires an over-the-wire exchange technique. So you first had to put in the balloon, inflate the balloon, dilate the artery, then put in the guide wire, take off the balloon, put in the stent, which is prone to technical problems. But there might also be a problem with patient selection. And some people thought you looked too short on this question and you need longer follow-up, that the medical group can catch up and have more events. But actually after 5 years, that didn't happen. So there was no major change in the outcome events, even if you look on the long term. There was another important study, also randomized controlled trial, the VISIT trial, which actually used a balloon-mounted stent, so to overcome these technical issues from the SAMMPRIS trial, which had actually more or less the same inclusion criteria, and intervention was more or less the same, except that they used another stent, which was a balloon expandable stent. And the sample size was smaller, 250 patients planned, and the primary endpoint was slightly different, stroke or TIA in the qualifying artery within 12 months of enrollment. Also, this trial was stopped prematurely after just 112 patients for the same reasons as SAMMPRIS, too many risk of strokes in the intervention arm. And you see this Kaplan-Meier curve looks virtually the same like the one from SAMMPRIS. You have very early increase in outcome events, and then both curves go the same way. But you already heard about this from Shadhi, actually. Although stenting was showed to be more or less harmful in these patients, probably, actually the medical arm was far away from being low risk. So we observed many outcome events, although also in patients in the medical arm. And if you, and this is a sub-analysis from the SAMMPRIS data, if you actually dichotomize patients based on the qualifying event into those patients who actually have border zone infarcts, so cortical or internal border zone infarcts like you see in these pictures, and you compare them to those patients who had actually what they call core MCA infarction, which is more or less an embolic infarct over here, or perforator infarcts, then you see that those patients who had actually a border zone infarct before going into the trial in the medical arm, they had a very high risk of having a recurrent stroke, 26%. And if you then put again the stenting group in a sub-analysis from the SAMMPRIS trial, so this is far away from being good evidence and not powered for any statistically significant differences, but you can see that then these curves separate very nicely, and you see that there seems to be some sort of superiority for stenting compared to medical treatment in patients actually having border zone infarcts. There was a post-marketing surveillance trial for the wingspan stent, which analyzed on-label use, defined as high-grade stenosis associated with at least two strokes in the qualifying artery territory in the US, which was stopped prematurely because it turned out that actually in everyday use and clinical practice, the event rate of periprocedural events was quite low, 2.6% in real life compared to nearly 15% in the SAMMPRIS trial. But you see that there are differences in the trial populations. You have all patients in the post-marketing trial actually had stroke, had refractory medical therapy stroke, and stenting was performed much later compared to the index stroke than in the SAMMPRIS trial. So there was virtually 3 weeks apart from the index stroke. So probably stenting in the acute setting is probably a bit of difficult or dangerous. This is just to give you an outlook that there are new devices and new techniques under development. Most importantly, drug-eluting balloons. There is one neurospecific drug-eluting balloon, but also balloons from cardiology have been used in intracranial arteries. This is a very, very subjective selection of presentation because this is data from Switzerland. You may find also other publications in the setting, and this is only small case series, so far away from any randomized controlled trial evidence, but I think there is some hope on the horizon. So how do we do it in Bern, actually? And so you can find our stroke guidelines on our webpage over here. We also have an English version for download and an app. And what we do in first ever strokes in patients with symptomatic intracranial stenosis, we actually go for dual antiplatelet therapy. We use aspirin 100 nanograms, which is more common in Europe, and clopidogrel for 3 months, then followed by monotherapy. And we always use a high dose statin. For patients who have a re-stroke with intracranial atherosclerosis, what we always do is that we repeat workup to be sure that we don't oversee any other embolic source like atrial fibrillation or cardiac embolic source, which actually require different treatments. But if we don't find any other cause and we are still convinced that it is the stenosis, then we sometimes go for stenting in these patients. And I have just 2 cases for you. This is a patient, a male patient, who came with this small border zone infarction over here, and in CT MR angio, you saw, it's very difficult to see, but you need to believe me that there is a very small and tiny supraophthalmic ICA stenosis. The patient got on intensive medical therapy, aspirin, clopidogrel, and high-dose statin, but unfortunately, he came back just 6 weeks later. Oops, that was too late. With 6 weeks later, with these new border zone infarctions over here, and we performed then angiography. You see this very small and tiny stenosis over here. We used wingspan stent and to stent these patients, and now more than 12 months after the stenting, he's still event-free. So this is a case where we use stenting actually in a patient who had stroke despite aggressive medical therapy. There's another patient who came in with these MCA core infarction, but also some border zone infarction over here. He had distal MCA stenosis. This is a MR angiography. We always use two modalities to verify any stenosis. So of course, this patient also got Doppler transcranial duplex ultrasound to find this stenosis, which was qualified as 70%. He got intensive medical therapy. He came back 3 months later without any new complaints, without any new infarction on the MRI, but we saw a progression in the MR angio and also confirmed by Doppler ultrasound, where we saw now a near occlusion 95% stenosis, and the patient was highly compliant with therapy. So what to do in the patient, because actually it's very difficult to do better in terms of medical therapy. And to help decision finding, we used perfusion MRI. And what we actually saw is that we saw a relevant perfusion deficit, which was also seen in cerebral blood flow. And then we did a Diamox challenge to assess the reserve capacity. And what you saw is that we have an increased perfusion lesion in the patient. But what we also saw is that the CBF stayed more or less stable. So there was no larger core. And so we decided, because this patient has reserve capacity, he didn't have any new event, to not stent the patient, but to continue medical therapy. And actually he came back 12 months later without any new infarction on intensive medical therapy. The stenosis is as before, but he had any new infarction. So this is the way we are doing it in Bern. Patients with asymptomatic stenosis, of course, don't get any stenting. If patients have first-time symptomatic intracranial stenosis, we go for aggressive medical therapy. And if they have recurrent stroke despite masked medical therapy, then we consider stenting. And so in conclusion, there is no role for stenting in asymptomatic patients, but in those who have stroke despite best medical therapy, we consider stenting. There are new devices and new techniques which are on the horizon, but we need randomized controlled data for this. So thank you very much and stay safe.
Thank you very much for all these talks. So I will leave the floor to Dr. Henninger, who will do the Q&A session. Don't forget, there's the special box for that. And just like to remind you that there's a recorded version who will be available on the WSO website for all your friends who couldn't join us.
Right, thank you. These were really fantastic talks. Thank you so very much for presenting today. There were quite a few questions, and I will try to mix them a little bit across the speakers. I think the most common question was the use of the various dual antiplatelets that are now available. And I think the most common question was about cilostazol. Is it being used? What's its role? Can anyone comment on that? And I think you have to unmute yourself. Yeah, perfect.
Yes, it's definitely a consideration. There's some data suggesting that cilostazol can reduce the progression of intracranial atherosclerosis. So it's definitely a consideration. My practice, I've used aspirin and Plavix, ticagrelor, but definitely cilostazol is definitely an option.
I might maybe add to this. What about now with ticagrelor? Is anyone using this? Because that's kind of flooding now the US market, and we are increasingly using it internally also, of course, with limited data to support that.
So we don't have cilostazol in Switzerland, so I don't have any experience with this, to be honest. But on the other hand, for ticagrelor, we used it in a few patients that had recurrent very minor strokes on dual antiplatelet therapy with clopidogrel and aspirin. So in these cases, or in patients that have who have any mutations which make clopidogrel very unlikely to work, we sometimes use ticagrelor.
Okay. Yeah, I have to say that ticagrelor, I reserve it for those that keep having a stroke, just because the data is stronger for Plavix and aspirin. The sub-analysis from the Thales trial that did 30% stenosis or greater, ipsilateral stenosis 30% or greater, it was a subgroup analysis of the Thales trial. So I think that is an option, and I'm glad that it worked in that subgroup analysis, but I think to use it in everyone before using aspirin and Plavix, I don't think we're there yet with the data.
Speaking of Thales, I think one of the questions was, of course, also the optimal duration of dual antiplatelet therapy. Are you more going by point chance Thales influence duration, or you stick to SAMMPRIS, which I think was 3 months?
I would say that it depends on the mechanism, right? So point and chance did not look at that. They enroll people based on NIH stroke scale, or TIA. And therefore, if you don't know what you're dealing with, sure, you can use that data. Chance later published the subgroup analysis with 50% stenosis or greater, and they found that the majority of the benefit actually happened in this group, in the Chance trial, and the duration of the benefit in the Chance trial and the subgroup analysis for stenosis was 2 weeks, which is similar to what point show, that 3 weeks, most of the benefit with DAPT occurs in the first 3 weeks. So, and it was 50% stenosis or greater. SAMMPRIS included 70% stenosis or greater. So if you know the mechanism, then I would say you can use the subgroup analysis from Chance or SAMMPRIS. If the degree of stenosis is greater than 70% or a flow gap, then I will go for the 3-month period that SAMMPRIS used. But SAMMPRIS did not compare any other duration of antiplatelet, so we don't really know whether a shorter duration would have been beneficial. I would say I would use it up to 90 days, but not beyond 90 days.
Okay, thank you. What about collateral status? That was one of the questions. In particular, is there any approach that could improve collateral recruitment?
I'll take this question. That's a great question. I think there's some data out there that suggests that physical activity can promote the development of collaterals. I'm not aware of any medication or any treatment that would improve the development of collaterals. I think they typically develop over time in patients with chronic stenosis, but there's some data out there that shows that physical activity can improve the development of collaterals.
One question was, I think we mostly spoke about the anterior circulation. I think the question is, could you use the developed tools, such as, for example, the presence of a border zone infarct and perfusion deficit? Could you use such information to do a risk assessment in the posterior circulation?
Yes, that's a great question as well. For the posterior circulation, and I apologize, I skipped the slide, but there's the VERITAS study that look at blood flow assessments and in patients with posterior circulation vertebrobasilar disease. And they used some software that's based on quantitative MRA assessments of blood flow. So this tool has been validated in measuring blood flow and posterior circulation. Perfusion imaging and Tmax has not been validated in these patients. Definitely, there are border zone infarct patterns and posterior circulation stroke, but the association with recurrence in these patients also has not been highly studied.
I think there were a few questions about how to best select patients who should undergo intracranial imaging with CTA and MRA. Are there any guidelines or protocols that could be used here?
I think that if the means are available, I think everyone should have arterial imaging, anatomical arterial imaging, or TCD, just because it changes slightly the management. As Dr. Yaghi mentioned, intracranial athero has one of the highest recurrent risk of a stroke, as opposed to, for example, small vessel disease. And the aggressiveness of treating the lipids, as well as the issue with dual antiplatelets, I think is relevant, knowing the degree of stenosis and the extent of athero. So every patient with a stroke should have some sort of determination of the mechanism, because that would dictate the subsequent secondary measures. So what do you use? Whatever you have available. If you have the three available, I would personally choose, if it's in the acute setting, I would do a CTA, which then I don't have to do it after, right? If someone comes with an LVO syndrome, then you do a CTA and you don't have to think about it after. If someone comes out of window for intervention, then I would probably do an MRA together with the MRI to reduce the exposure to radiation. But yeah, it all depends.
Okay. This is a question that came up a few times that I really like. So Shadhi, you mentioned induced hypertension or blood pressure augmentation, which I must admit we also use in our institution, but I frequently find rather frustrating, to say the least, and really of durable effect. And I think prior studies have not shown durable effects either. So the question is, how do you choose your patients to do this? And if you do it, for how long? And what's the overall rationale here?
Yes, I mean, this is just based on small reports, and there's no good evidence for it, and it should definitely not be used on all patients. There are a small minority of patients who do have a pressure-dependent exam, and this is, again, my practice is to try to treat them with fluids, keep the head of bed flat, and see if they would improve, and then just if they don't, then I think that there's still some sort of mismatch or perfusion deficit that they have that's symptomatic. Then you can try giving them some blood pressure other blood pressure augmentation strategies and see if there's any effect. It should definitely be a very brief treatment duration, and it should be in very, very limited number of people used who clinically have a pressure-dependent exam and who do show improvement with blood pressure augmentation.
There are quite a few questions regarding stent-specific approaches. I think we will not go into this. That's more for an interventional group to answer. But there are related questions that I think are important. For example, how do you choose antiplatelet therapy in a patient who did undergo stenting? And what is the, I would say, utility, if any, of platelet function tests in patients in general?
So I guess this is for me probably. So I think the standard for treatment is that they have aspirin and they have clopidogrel, and which is very important is that they have some kind of loading dose and prior treatment. So you can't just go for stenting in a patient who has never had any any aspirin and clopidogrel before. So this is prone to cause many problems with the stent closing just when you put it in. So usually we put these patients on dual antiplatelet therapy a few days before stenting, if it is elective. What we sometimes have as a problem is that we have patients coming in for mechanical thrombectomy for acute stent, for acute stroke, and then we figure out that it's actually an intracranial stenosis which is now closed or which caused large vessel occlusion. And then you have the question whether after performing mechanical thrombectomy, you put in a stent directly. And we are usually try to avoid whenever possible to put in a stent in the acute setting. But sometimes it is, you can't avoid it. And then we actually give aspirin intravenously as in high dose, and we perform very short follow-up CT to rule out hemorrhage and to start clopidogrel quite soon. And we go for at least 6 months in dual antiplatelet therapy for these patients if they got a stent intracranial. Then we decide, depending on the Doppler exam on follow-up, whether we continue a bit more for dual antiplatelet therapy or we can switch to single dose.
Maybe the others can also comment the use of platelet function tests in your institutions. Are you using it or not?
We're not using it routinely.
Yeah, we don't use it either. At Columbia, we just treat it specifically for clopidogrel, I guess.
Yeah, same here. We don't use it very commonly.
Okay, let's see. There were questions before. I'm not sure if they have been answered now. What do you do with a completely occluded vessel? Do you think dual antiplatelet therapy is still of utility there? And a related question, which I also find interesting, particularly since patients always ask, is what happens to the thrombus that's sitting in the vessel? I'm not sure if that has already been answered, but I don't see the question anymore.
I typed an answer, but so what happens to a thrombus, as I show you in the slide. So there's 3 fates. One is it can autolyze, and your own body take care of it. We have mechanisms for that. Second, it can grow and occlude the vessel, and from that there's 2 options. One either stays there and completely occlude the vessel, and that's it. And as I can show you, sometimes it can recanalize, or it can break off and be a source of artery embolism. So those are pretty much the fates of a clot.
I may add there's a 4th mechanism then, that you have some transmigration of clot material through the vessel wall and it's cleared that way. I think there was some nice data from Yale a few years ago. The use of dual antiplates in a completely occluded vessel, do you think that's of utility here? And if so, when? Under what circumstances?
I think it depends on the mechanism again. So if it is if you see that it is acute occluded vessel, so we would probably try to reopen it and mechanical thrombectomy if it is within the time window. If it is an occluded vessel which caused distal embolization and so caused acute stroke, and which is in the not anymore possible to open it, then I think probably dual antiplatelet therapy for a few months would be of utility, because we see this from carotid occlusion that you sometimes have even in occluded vessels, you can have distal embolization from the vessels. So I think it's probably of utility.
The one question was how to manage multiple intracranial arterial stenoses. I guess a related question would be, do you think there's a difference how to manage patients if you see a single vessel disease in general versus multi-vessel disease? Does it give you any clues about the pathomechanism? So it's a 2-part question. One part I made up on the fly because I think that's a common issue we're facing too.
I would manage it the same way medically. So one area of high degree stenosis as opposed to multiple, aggressive medical therapy is the way to go at first. Now, in terms of what it means, so and again, I'm a little biased by my experience in pathology, and in pathology, you rarely see isolated athero. I mean, it doesn't exist in pathology. But the problem is that when we see on lumen-based studies a vessel or a single point of high degree stenosis, I always wonder what it is, the underlying pathology, because athero, even that is a more diffuse disease, typically you see, sure, an area of high degree stenosis, but you see multiple luminal irregularities throughout the brain. You say, oh, this is intracranial athero. What to do when there's a single stenosis with perfectly normal vessels around it and throughout the circle of Willis? I typically tend to look for something else. And if I have access to high resolution Wool imaging, I would use it. But still, if I don't have a diagnosis, then I opt to treat for athero, because treating for athero is perhaps the highest yield. And if it is athero, then I don't want to, I don't want my doubts about the etiology get in the way of potential benefit to the patient.
There are a few specific questions, I think, for David. In the failed optimal medical therapy group, when do you advise to stent them? And what is the duration from the index stroke? And in terms of the number, do you see more hyperacute stenting or elective ICAT stenting?
Yeah, so this is a very good question. We actually, for the time from index stroke to stenting, having in mind these data I showed you, we try to wait a bit, to wait at least a few days. Optimally, you would wait for 1 week for the stenting, especially those patients who probably have a large infarction and with a high risk of bleeding. So if you put them, or if you have additional antiplatelet therapy and reperfusion damage, you don't want to have this in the patient. So I think probably wait a few days if you can wait for recurrent stroke. From the number of patients that we see for stenting, to be honest, I have to tell you best guess. I think it's half-half. We're seeing a lot of acute occluded intracranial artery stenosis patients coming in for thrombectomy. So we have probably once or twice a month a patient that we have to do stenting in the acute setting, because even after thrombectomy, still in the angio suite, the vessel gets closed or occludes again. And from my personal experience, these are always cases they don't have good outcomes. So because these vessels re-occlude even with a stent, and you have a lot of bleeding. So probably it's half-half, but these acute stenting is not very good thing to do.
How common is aspirin clopidogrel resistance? I guess we might not be the best people to answer from our institutional experience, since we don't check it. And I think another question is, of course, what's the definition thereof? But maybe you have oh, I think you already answered it. But anyway, if you want to comment, please feel free.
Yes, I don't know at the top of my head the exact number, but I'd say from what I recall from the chance and point post-hoc analyses, perhaps 25% of patients have the mutation. But again, it depends on what test is being used, but the mutation, I'd say roughly maybe 25 to 30%.
And what does it mean for your practice then, if you think that this is happening? How would you define it? A recurrent event, and then you'd switch, or what do you do?
Yes. So, it's definitely an open question. There's a lot of controversy. And interestingly, in the chance post-hoc analysis, looking at patients who had the mutation, there was no benefit from adding Plavix in these patients over aspirin. Versus those who don't have the mutation, Plavix continue to be effective. Now, in the point post-hoc analysis, there was no difference. So it's still an open-ended question. I don't think we know. I often, if someone, as David mentioned earlier, if someone has a stroke despite being on aspirin and Plavix, and I don't see any other reason for them to have a recurrent stroke, and their We don't routinely check it, but sometimes we do check a P2Y12 level in this setting, and if it's elevated, then I tend to switch them to Brilinta. But again, there's no strong evidence behind this, and there needs to be a lot of research to investigate Plavix resistance and whether it has a clinical effect on recurrence risk in these patients.
There's one last question, if you have the time to answer this one. It's regarding the use of the Diamox challenge. I guess the question is, do you like, what is the dose of Diamox and the timing of the scan? And I stay away from opening Pandora's box here regarding other approaches for bypass and so on and so forth, where we also use that. But can you briefly comment on the Diamox challenge test?
To be honest, I'm not a neuroradiologist, so I must say that I don't know the exact dosage that they gave in our patients. So I think this probably depends on your local protocol. Probably there are different protocols available. To be honest, I'm not the right person to answer this question. But we use it regularly for this type of evaluations, and I think we have some quite good experience with it.
So I think we're at the end. We actually answered, I think, all the pertinent questions. I apologize to everyone who asked questions, which I edited and took out or maybe rephrased a little bit. But thank you for the speakers for joining us today. It was really a very inspiring talk, very interesting. I actually have a million more questions that I'm really refraining from asking. Thank you again, everyone. And thank you for the audience for joining us. Have a good day.